Chris Hopson, thank you very much for joining us on T&G this morning.
Good morning.
We're seeing close to 600 new patients admitted to hospital a day now. That's obviously well below the all-time peak of 4,000 a day in January, but it is a number that is continuing to increase. How are hospitals coping at the moment with COVID cases?
Well, let's answer that in two ways. So first of all, let's talk about the numbers. So yeah, we're about sort of 3,500-ish, and effectively what we're seeing is that those numbers are just about doubling every fortnight. So we could be talking about 7,000 at the end of July, 14,000 in the middle of August. The real question is, when does this cap out? In other words, when does the community infection rate start to peak? And we know there's probably a couple of weeks lag on hospital admissions, and that there's a really interesting debate going on at the moment about, will it cap out at sort of below 10,000, or will it cap out at potentially below, more like 20,000? And what's deeply fascinating is nobody knows, and there is a real sense of we just don't know at this point. Then the second bit, which I think is a really important bit, is how busy are hospitals? And of course, if you just concentrate on the COVID-19 admissions, you get a completely misleading picture, because what you need to look at is the entire picture. And what we've actually got is going full pelt on the backlog recovery, very, very busy, often record amounts of urgent and emergency care demand, 15,000 beds down from where we were pre-COVID because of infection control, and then large numbers of staff having to isolate. So if the river is already full and the ground is sodden, it doesn't take many extra COVID cases before hospitals are under real pressure. And in fact, the rest of the NHS ambulances are under huge pressure at the moment. So I'm struck, Tom, by the number of chief executives who said to me in the last week, this is amongst the most busiest periods that they've ever experienced. And as I said, there's this slightly weird thing about, on the one hand, the COVID admission rates are actually much, much lower than they were back in January. 34,000 people in hospital in January, 3,500 now. It's the issue of all of the demand and the staff and bed capacity constraints that are actually making it very, very busy.
Okay, so it's not quite a like-for-like comparison with the business, just the simple COVID admission rate in January, I accept. But let's just break those two down. Your latter point first, in terms of how busy hospitals are now. Why are they so busy? If COVID admissions are 600 a day rather than 4,000 a day, where they might have been in January, why are hospitals so full in what's the lovely warm summer months?
Well, because we have got much, much more emergency care demand than we had in January. And clearly back in January, we were doing quite a lot of elective work, particularly, surgery work, particularly the really urgent, cancer work. And, never want to give the impression the NHS stopped providing COVID care, because it absolutely did. But clearly the rates of, non-COVID care we were doing were much lower. We're now trying to go full pelt to recover all of those backlogs. So it's the combination of the rising COVID work meets the full pelt on backlog recovery, meets record levels of urgent and emergency care demand, then the capacity constraints. It's the combination of all of that that's making hospitals so busy. And if you don't mind, Tom, we do get a bit frustrated when people say, oh, look, the COVID admission levels are so much lower. That's not the point. The point is, please look at the whole picture. Don't just look at the COVID bit of it.
Understand. So obviously the follow-on question to that from me would be, how many more COVID patients can hospitals now take? What level of doubling, you were just referring to, hospitalizations are doubling every couple of weeks now. What level of doubling do you get to before hospitals simply start saying, we're just too full, we're going to have to start cancelling vast amounts of elective surgery? Some might already be cancelled now, but vast amounts is going to have to stop, and we're going to have to start thinking about opening those emergency Nightingale hospitals again.
Well, this is the point where, to be frank, Tom, the kind of talking about a single national picture simply breaks down really very quickly, because what happens is that actually you need to look at what's happening in each individual region and, to be frank, in each individual hospital. So what we're finding is that in some places they're coping fine because the community infection rates are not particularly high, but they haven't got the same levels of staff off. They perhaps had larger bed capacity than some others might have done. Whereas if you go up into the northeast, what you'll find, and it seems to be the northeast Northeast that is really, in a sense, at the front of this particular kind of wave, what you are finding is some of those hospitals up there are having to cancel elective surgery and increasing amounts of it. So, and Tom, I've been asked by 4 or 5 people this week, what's the magic figure at which it gets really difficult? And the answer is you can't really do that on a national basis. It's done on a hospital by hospital by hospital basis. And just one more bit, it's not just hospitals that are busy. Ambulance services are just, as I said earlier, really under pressure. We know that mental health, I mean, one chief exec said to me last week, we're now experiencing our own pandemic in terms of people who are coming forward for mental health, and community services are incredibly busy as well as a GP. So it's not just hospitals that are busy, it's right the way across the NHS that we're busy.
I understand, but I suppose that the real working part for this when it comes to government decisions is at some stage, hospitals will become so busy that the clamour from the likes of you, from NHS trust chiefs, from many others, will be, we have to now start putting on the handbrake in terms of opening up. We're going to step 4 on Monday. That is effectively a free-for-all in terms of legal restrictions. There's a lot of guidance being issued, of course. So, Chris, are you happy to see the entire nation move to step 4 on Monday and all those legal restrictions to go, or are you already concerned that might be too early?
Well, I think it'll depend upon public behaviour, won't it? I mean, there is that famous Jonathan Van Tam phrase of let's not rip the pants off it. I mean, there is absolutely kind of, if people behave in a responsible way and effectively they don't just completely go at it, then that's a very, very different issue from everybody deciding on, Monday that bang, they're going to not wear masks anywhere, have massive parties everywhere, etc. So it will.
So that begs the question. Are we wise enough? Is the government wise enough to just leave it down to what could be a lottery of how the general British public behave?
Well, Tom, we've been really clear about this all the way along, which is that only the government can balance all of these different requirements. And effectively, our trust leaders do not believe it's their job to balance the economic, social freedom, health issues. We're very, very clear about the health risks here. The chief medical officer has been clear about those risks. So effectively, and we can see the logic, and we've said that publicly. We can see the logic of why these restrictions have been eased now. And they're absolutely right to argue you can't do it closer to winter, given the seasonal impact that we know winter's going to have on COVID prevalence rates. So if not now, and absolutely you can kind of see the need to live with COVID long term, but there are risks here. And as I said, the fact that when I ask our senior leaders, so what level of hospitalizations do we think we are going to see? How's it going to cap out? The fact that nobody can answer that question because we simply don't know. That's an illustration of the level of risk that we are running. But you can see the reasons as to why the restrictions have come off.
No, understood. I think we can just conclude this debate about capacity by simply saying it is indeed possible that hospitals could, or no, not necessarily will, but could be overrun if things go the wrong way from Monday.
Well, I think you need to be careful about the word overrun, because the whole point about being a trust chief executive is it's your job to basically balance all of these different factors, spin as many different plates, juggle lots of balls, and make sure you provide as much care to people as possible. But the thing we said last week, Tom, and we're going to say it again and again, is that there is no doubt that as the number of COVID cases rise, particularly if we have large numbers of staff self-isolating, is we will have to dial back on the element we can control, which effectively is the elective surgery. So you are already seeing that happening in places where the COVID load is high. So, this is not going to be, consequence free. And we again need to be really honest about that and open about it.
Let's ask those 2 versions of the questions now on self-isolation. I'll ask the version as if there was no government announcement first.
Yeah.
Chris, there's been a lot of debate in the last few weeks on self-isolation. Vast amounts of people are getting pinged by the app or by test and trace and having to isolate. How is self-isolation affecting hospital staffing levels? Because, of course, NHS staff still have to isolate us just like everyone the rest of us.
Well, it's a classic COVID dilemma, isn't it? You've got 2 competing objectives here. On the one hand, we've got to try and control the community infection rates, and we know that self-isolation is key to doing that. But actually, the way the app is currently working is, in a sense, quite rightly, is large numbers of people are having to self-isolate. So how do you control those 2 objectives? And the NHS, just like a number of other places, is coming under real pressure. So we've said to the government, and we know they're thinking about this, is can we find a way that in places that are under real pressure, where there is danger of harm to patients or where patients' lives are at risk, can we find a way for NHS staff, as long as we can be as confident as we can be they're not infectious, can we get them back to ensure that, you know, harm is not caused. So that, I think, would be a good way of making this work. We're hoping the government will decide that really very, very quickly.
What sort of staffing levels are trust chiefs telling you that they're suffering at the moment? 5% off, 10% off?
Well, so it varies by trust, but I'll tell you one thing again that we were talking about last week, which effectively is there's one trust that said to us that if you add together the fact that you get an ordinary sickness rate, we're about to hit peak summer leave, and we know that the impact of that will be much greater this year because there's large amounts of leave have been left over from late last year in January, February. And if you then add their projection of what would happen in terms of self-isolation as community infection rates rise, they were predicting, pause for effect, 20% of their staff being off. And that effectively would have meant having to cancel 900 elective operations. So there is a really big impact here. And as I said, it's exacerbated by that summer leave issue.
900 different operations cancelled by one trust.
Yeah.
Wow, that is a lot. Let me ask the question the other way around now. So, Chris, obviously there's been a huge amount of pressure on hospitals and GPs with their staff having to isolate. We've heard the government's announcement now that there's now an exemption in place for some staff if they don't have to stay home for 10 days any longer. If they're pinged, they can do a test. Is this enough to relieve staffing capacity problems at hospitals, or should the government have gone further?
Well, this has been a classic COVID dilemma that we've kind of had to solve. On the one hand, we know that self-isolation is absolutely fundamental in terms of ensuring that we bring the infection rates down, which is what we absolutely must do. But on the other hand, you know, particularly in the NHS, we kind of need to keep going. So it felt to us that this is a sensible compromise. I don't think I'd quite describe it as an exemption. What I would say is that if a trust is in real danger of its patients coming to harm and effectively lives being affected, then it can find a way of ensuring it can amend its infection control processes to make sure that if somebody is self-isolating and they've tested negative, then actually, you know, the number of staff that is needed to ensure that actually harm is not caused, they can come back to work. And that feels to us to be a sensible balance to strike between these two different objectives. But this is another kind of classic, you know, a dilemma that COVID has thrown up at us. And it seemed to us to be a sensible way of resolving it.
And let me ask you about something else. I know NHS providers have been quite concerned about a general public debate last week in terms of coherence of guidance. It hasn't been altogether clear what every different NHS trust should do, every different GP surgery should do in terms of infection control. What should be the rules inside hospitals or surgeries for wearing masks and that? Because the government have been saying it is no longer the government's job to set these anymore because they're moving down to individual responsibility on the ground. How's that working out in hospitals, or would you prefer general guidance issued from the governments for every healthcare setting across the country?
Well, the government needs to decide what happens across the economy as a whole, but we think they need to be really clear that in healthcare settings, there's a different, you know, there's a different set of rules here, and that's because we know that there is risk of acquiring COVID in hospital because we've got lots of vulnerable people who've got lower levels of immunity. And don't forget, this is a variant that's 60% more infectious than the previously dominant Alpha variant. So we've been clear that we thought it made sense to have a single NHS-wide approach. What we would like is government ministers to kind of be very clear about why the NHS needs to be different because of these requirements. And Tom, there's a particular reason why this is becoming important, which is I was very struck by the number of chief executives who were saying to me at the end of last week, they were seeing increasing numbers of very aggressive, very determined members of the public asserting what they believe is their right to not wear a mask, not socially distance, not observe the rules in terms of visiting rules, because we are about to hit Freedom Day, and that was before Freedom Day has even been hit. Unfortunate phrase, I think, in some senses. And therefore, what we actually kind of need is we need ministers and we need national NHS leaders to be very clear that it is inappropriate for people to abuse and confront NHS staff who are actually trying to protect patients, protect visitors, and protect their fellow members of staff. And as I said, if we see more of these incidents, which I suspect we might do after tomorrow, then the voice from the NHS saying to the Prime Minister and others, could you please be really clear that zero tolerance if you do not observe NHS rules, and particularly zero tolerance if you abuse busy NHS staff trying to protect themselves and trying to protect patients, that, you know, the call for that will become deafening, because we can't be in a position where our kind of tired staff who've given so much are being abused for trying to protect people. It's just not on.
So that's something you want the Prime Minister or the Health Secretary to say today or tomorrow: do not abuse NHS staff, wear your mask if they tell you to, because they're trying to keep everyone safe.
Yeah, it's really, really clear. The rules are about NHS healthcare settings is that, you know, you need to wear a mask. And the reason you need to wear a mask is because there are vulnerable people there who actually, you know, you could infect and they could end up dying. So absolutely, we do want ministers to be clear that it is not acceptable to abuse NHS staff who are trying to protect patients and other staff.
Let me ask you one more concern that seems to be certainly one growing in the healthcare world, and that is the capacity to perform PCR tests. If you're told to isolate, if you think you have COVID, of course, you have to go and get a PCR test. Many more thousands of people are trying to do this. And we're now beginning to hear about delays in terms of getting your PCR test result back, up to 2 days, but in 3 days, you have to wait for it now because the capacity is so stretched. What's the capacity like in hospitals, healthcare settings? Can you get your test done in time?
Well, I think in general, we know that what happens at various points is that the upward demand curve for PCR tests isn't uniform. In other words, what happens is you get spurts of demand, and we absolutely hit a spurt of demand last summer, if you remember, particularly when, you know, school's about to go back, etc. And if you remember, that put real pressure on capacity. So it's very clear now that we are looking for a higher volume of tests than we've currently got capacity for. That capacity is being expanded at real pace. I think one of the observations I'd make, Tom, is that I do think our friends at Test and Trace in some senses have actually been given a really pretty hard ride. I think they're an impressive operation given the constraints with which they've been working in their context. And we know they're going absolutely full pelt, supported by our hospitals. They obviously control their own capacity as well, to basically expand that capacity. I'm told that by the end of the month, actually, we should be at the capacity that we need. So I suspect this will be a temporary kind of pressure that won't last too long, but we're going full pelt, and I know they're going full pelt to make sure that capacity does get expanded, because we've hit one of these spikes of extra demand.
Well, here's certainly hoping. Daisy's got a couple of questions for you.
Thank you very much. I want to ask you in a moment about people who have been vaccinated who are now coming down with COVID and testing positive, because I think this is something that people aren't quite clear about and where that's going to go. But just before that, I wanted to mention a letter that was written to the Lancet at the end of last week, in which 1,200 scientists have condemned what the government is doing. They've said it's a danger to the world. These are global, they're official advisors from New Zealand, Israel, Italy, many other countries. They've said that it's a danger to the world. So David King has said it's completely the wrong decision in opening up tomorrow, a so-called Freedom Day. The Lancet editor who published this letter, Richard Horton, has said that Professor Whitty has willfully misrepresented scientific opinion when he said that generally scientists were on board with the government decision. And I just wonder whether this is your experience, that the rest of the world is looking at us aghast.
Well, Daisy, we said all along this was a really difficult decision to make. I mean, in our view, the previous kind of going in and coming out seemed to us to kind of be much more kind of simple and obvious. I think this one is really, really difficult. And it's clear there are very, very different views here. And we know there are risks and potential adverse consequences. And, you know, again, if you don't mind me saying, I really do have a considerable sympathy for a government that does have to make such a difficult decision. They've made that decision on the balance of the evidence. I think we will see kind of what happens. I'm not going to try and second guess, because one of the things that is really obvious about this pandemic is you simply don't know how things are going to turn and go forward. So, you know, a decision has been made. It's got risks to it. We're going to need to see what happens.
No, I totally understand that. But I guess what I'm getting to is, or what I'm getting at is, are you in touch with your contemporaries around the world, which I'm sure you are, particularly in the middle of a pandemic? And is that what they're saying to you, that they're looking and saying, we wouldn't do what your government's doing, we think you're mad?
Well, if I'm honest, actually, we're so busy, we don't actually have much contact with our kind of, similar organisations kind of across the world. I do recognise, that people who think this is the wrong decision have been marshalling that argument, saying everybody else is looking at us and saying we've got it wrong. And again, for me, it's just another sign of the fact that this has been a very difficult decision.
Yeah, and I guess we're the guinea pigs, so we'll have to wait and see. Just on this subject of vaccinated people getting COVID, the Zoe app seems to be suggesting that 47% of new cases are people who've had at least one vaccine. Would you agree with that? And is that a surprise?
Well, you need to be really, really careful about statistical anomalies as a result of kind of what's going on here. So when you get very large proportions of the population vaccinated, it's not a massive surprise that you get some interesting percentage figures going this way and that way. So it's been really, really clear over the last 2 or 3 months. We've been saying very clearly that there are relatively few cases of people who've been double vaccinated. There are some, and we know there would be some because the clinical evidence shows that the vaccines aren't 100% effective. And we do need to remember that the consequences of catching COVID can be really, really difficult. Very interesting Lancet study this week showing actually about half of people who are hospitalized with COVID end up having a complication, and a potentially significant complication that requires either further surveillance or further treatment. So there will be a small number of people who, because the vaccines aren't 100% effective and have been double vaccinated, where they will catch COVID. But the vast majority of cases that are coming in are either basically usually unvaccinated, particularly younger people, though there are a few people who have older groups who in older age brackets who haven't been vaccinated. And yes, there are some people who've been single vaccinated. I think the evidence shows that if you've got a single vaccination, the level of protection is about kind of 40%. Yeah. So, as I said, it doesn't surprise me to hear there are individual cases, but you can see from the mortality rate and you can see from the hospitalization rates that double vaccination offers a very, very significant level of protection. I think it's 94% for double AZ and 96% for double.
Absolutely, but I just wonder whether people think therefore they're 95% not chance of not getting it, whereas of course the chance of getting it is half that. It's the chance of ending up in hospital, but you still could be quite ill and you're still going to have to isolate, miss work and everything that comes with it.
Yeah, and again, I don't know about you, Daisy and Tom, but I certainly have come across 2 people now who've been double vaccinated in my world, my work/personal world, who effectively have been double vaccinated and have kind of caught it. I know Stan was saying that the other day that he was saying that he'd had to. What particularly interested me is one of those people really is quite ill at the moment and effectively is one of those people for whom COVID has been really very difficult. And they're saying they're waking up every morning hoping that today will be better, but 4 weeks later it's still not the case. So this is again one of the risks that we want to really, really point to, which is less than 100% vaccination does basically mean that there is risk here.
Yeah. Tom.
Chris, let me ask you just a couple of quick non-COVID questions to end. We're told we might just see the Prime Minister's new plan for social care this week, the one we've been waiting some 2 years for, if of course he can do a deal with the Chancellor first. You've called for this plan ASAP. NHS providers want this plan out immediately. Why is that?
Well, because we know that effectively health and care are 2 sides of the same coin, and we know that social care is in a completely unsustainable place at the moment. It's not just the issue. Everybody tends to concentrate on social care reform, on the issues around what should the level of people's personal contribution be to their care, but there's a whole bunch of other issues. The workforce model is increasingly unsustainable. What we also know is that the number of people who are eligible for care has been dropping because the thresholds have been raised higher, and there are people who ought to be receiving care who aren't. We know that local authority finances are in a really, really difficult place in terms of funding those people who need state-funded care. So there's a whole bunch of issues that need to be solved here. It's not just sort of the deal not cap issue, if you don't mind me using that kind of phrase, about how much, where the cap is, about how much you personally contribute. So, and we've been arguing for a very, very long time that we need a comprehensive plan addressing all of those issues kind of, to come forward. And to be fair, it's very complicated and difficult, and it's probably very expensive as well, but we absolutely have to have it.
And there are unprecedented numbers awaiting assessment and awaiting care places, I believe, and they're taking up hospital space right now.
Yeah, absolutely. And I think, one of the things, though, to be fair, that one of the things that has worked, but hey, good in a sense, if you don't mind, I'm going to grab the question, which effectively is that one of the reasons actually as to why that problem isn't as great as it's been in the past is that actually we did put in some special funding called Discharge to Assess funding, which effectively enable people to come out of hospitals and then be assessed in the community or in a halfway, like an intermediate bed. And there's a real question about whether that money is going to be extended for the second half of the year, because one of the issues that is coming up is the NHS's budget was only decided for the first half of the year. So it's really, really important that we kind of get all of this right in terms of, particularly as we head into what we know is going to be a difficult winter. If we find that we have anything like the levels of people who need care stuck in hospital beds this winter, we are going to have a real problem. So that combination of longer term social care reform, but also ensuring that Discharge to Assess money keeps funding keeps flowing is really, really important.
And finally, we're also expecting to hear from the government on the NHS pay review, how much doctors and nurses are going to get paid in years going forward. What level of pay would trusts like to see for their doctors and nurses?
Well, I think we're very clear that the 1% offer that was originally put forward was inadequate. And indeed, we'd all been working on when the May government extra NHS money came in, there was an explicit assumption was made that it would be at least 2.1. We surveyed our members, we gave evidence to, as we always do, the NHS pay review body, and we asked our chief executives what did they think. And they said they thought that 3% was a minimum. So I think, you've got on the one hand, the 1%. I really don't think that the Royal College of Nursing's 12.5% feels feasible. So I think it will be somewhere in the middle. I would expect this, and I think a reasonable place for it to land would be 3 to 4%. That's what I think where the Scottish government were. They're the higher end of that bracket. But interestingly, nurses in Scotland weren't particularly happy with that. So I do think there is an important issue here. The key point, Tom, is our staff have been working incredibly hard, and it feels to me it is right and proper that we should recognise the contribution that those staff have made. And it was delightful for the NHS to receive the George Cross, but actually we also need to ensure that hard-working frontline NHS staff are also paid and remunerated at an appropriate rate, and the effort they've put in over the last year is properly recognised.